is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. There's no magic bullet to restore access to abortion in the United States. Those words came from Secretary Xavier Becerra in late June, the head of the U.S. Department of Health and Human Services, the same agency President Biden has tasked with finding ways to protect access to abortion and making sure pregnant patients get emergency reproductive care no matter where they live. Today, Where We Live, we talk to doctors providing reproductive care in Texas and North Carolina. We also talk to providers here at home. Coming up, we hear from Dr. Kate Pascucci from Connecticut Women OB-GYN and Dr. Amanda Kallen, Associate Professor of Obstetrics and Gynecology at the Yale School of Medicine. What questions do you have about the future of reproductive care in the U.S.? You can join us, 888-720-9677. That's 888-720-WNPR. You can find us on Facebook. Search Where We Live. My first guest on the show, joining us on Zoom, is Dr. Jessian Munoz, a maternal fetal medicine specialist practicing in Texas. Dr. Munoz, welcome to our show.
Good morning. Thanks for having me.
Now, you practice high-risk maternal care. And so I'm wondering if you can talk through with us when patients arrive in your office, normally the kind of care that you're providing.
Yeah, so I am a high-risk specialist, also known as a perinatologist, and about 1 in 3 women will ultimately end up in the care of a maternal fetal medicine specialist. So many of my patients have already been seen by their obstetrician and identified to be high risk either for maternal conditions, fetal conditions, or conditions that are particular to the pregnancy. So it could either be, mom is very sick, the baby has a fetal anomaly, or the pregnancy is more complicated, such as twins, triplets, or problems with the placenta.
And so they're usually much further along in pregnancy by the time they come see you?
Yeah, on average, by the time they come see me, they're probably about anywhere between 15 to 20 weeks. We do a screening ultrasound for all pregnant women between 18 to 20 weeks. So many women come during that time.
I'd mentioned that you practice in Texas, and we know about Texas's law that was enacted in September of last year that would ban abortions past 6 weeks. And so when that law went into effect, and I know with all of the different court rulings and now the Supreme Court ruling, I wonder if you can talk about, the conversations that you may have had with patients or even colleagues about the moment that we're in.
Yeah, ever since the passage of SB 8, it's been a wild ride. And it's been a wild ride in all aspects of the care that we provide. A lot of my care provided is in the office as a consultant. And so I do have a number of patients that will come to me, as I mentioned, either with like a maternal high risk condition, such as a cardiac condition, or, stages of cancer. And then other times they come for a screening ultrasound, which we do for all pregnant women, and we find something. We find a brain anomaly, a cardiac anomaly, a missing portion of the fetus, for example. And so, those conversations have obviously changed in the last 9 months since, my job, and I always tell patients, my job as high-risk OB is to provide the risk profiles for all the viable alternatives and then allow you to decide what's most appropriate, what risk you're willing to take. And so the first barrier that I find is right there. I can't really discuss all of the risks or all of the options, as termination of pregnancy would not be an option within our state. And our state is so large, you could drive for 14 hours and still be in the same state. So referring a patient outside of the institution is also very difficult, especially since patients have probably already driven 2 or 3 hours to come and see a high-risk specialist. So that definitely does impact the office care. And then, we do work on labor and delivery as well. And one of the best parts of my job is just that you never know what's going to come through the door. And labor delivery is always a very exciting place to be. But, the more recent environment has more of fear. You don't know what's going to come through the door. And, what 18-week massive bleeding patients are going to come through, or how sick are they going to be? And you don't know what's coming through. So talking to colleagues and experiencing it myself, there's been a lot of fear as approach to things and a lot of second guessing, trying to protect yourself, but also provide the best care that you can.
When you say having second guessing and having to protect yourself, so you're referring to, I believe, this other law, this trigger ban that was passed in Texas that would create harsh penalties for providers and doctors for performing or aiding abortions at any stage of pregnancy.
Correct. Yeah, especially that aiding part. So like the verbiage for the aiding and abetting it's very broad. And so when that first was enacted, we had a meeting within our group, and we were like, you have to be careful. Like we do have partners in the room with them, and the partner could be recording any part of this conversation, where you could be telling them, patient, there is an option for termination in a nearby state. That would be considered aiding and abetting.
Mm. Wow, that puts you and your colleagues in a really hard place when you think about why you entered medicine, to help your patients get the best care, and to feel that you are hamstrung and could face legal penalties. That must be really frightening too.
I chose to go into OB because it was supposed to be the happiest field. It's the only place in the hospital where patients are happy to be there in the hospital. And now it's become quite terrifying.
Mm. Again, you can join us as we talk to OB-GYNs this hour. My first guest, Dr. Jessian Munoz, who's a maternal fetal medicine specialist who practices in Texas. Our number 888-720-9677, or find us on Facebook and Twitter at Where We Live. Dr. Munoz, for your patients who decide that they want an abortion, what does that mean for them in the state of Texas? As you mentioned, they would have to travel out of state, and the difficulty of that because of so many different factors.
There's so many barriers. We have included so many unnecessary barriers for women to access care that it's just become ridiculous. As a consultant, we are the only academic maternal fetal medicine group for a very wide range. And I mean, 7 hours west, there's still nobody else. So we have patients that travel to many hours to come see us. And then once we give them the consult and their options, then they may need to travel an additional 5, 10, 12 hours to another state to get care, if they can even arrange it in another institution. And it would be across states. So obviously, there's no insurance coverage either because it's not their home state. So the costs start to pile up on patients that already, are set behind, and, may not, especially in the setting of the pandemic, may not have a $2,000-3,000 lying around to go seek their care.
I wanted to bring in another doctor into the conversation. Dr. Kate Pascucci is a doctor here in our state with Connecticut Women OB-GYN. Dr. Pascucci, welcome back to our show.
Hi.
Now, we talked with you right after the opinion from the Supreme Court was leaked in May, and we talked through some of your thoughts. As you hear a colleague in another state who is dealing with what the laws mean in terms of how he and his colleagues can provide care, how do you respond?
I mean, I can't imagine the barriers that people are facing in that, especially like in Dr. Munoz talked about how large of an area Texas is. I mean, that provides so many issues for women and for doctors who are trying to provide good care to people. I can't imagine the confusion probably in some of the units and some of the offices on what exactly the laws are. There's a lot of talk through Facebook groups of OB-GYN doctors in states with trigger laws and about like what exactly is allowed and what isn't allowed. And people are confused and they want to provide really good care for women. I think a barrier to care is understanding exactly, I mean, the laws in and of themselves are problems, but then like trying to understand what exactly are the laws, what you like, sometimes, if you do the right thing, are you gonna face legal ramifications for that? I mean, these kinds of things are things that I think would really provide me with a lot of anxiety.
You also provide abortion care to those patients who make that decision in our state. Can you talk about how you approach these conversations and, since this ruling came down, some of the concerns that you may have heard?
Sure. When patients come in and, it's usually that, we talk through the options, we're able to get ultrasounds, figure out how far along people are, and we're able to support them in whatever decision they make. People are concerned now about the future. And if I think people are like, people come in and be like, better get my IUD now, better, figure out what I want to do for birth control in the long term. People are nervous that this is I think in Connecticut, people are nervous that this is only the start of, picking through reproductive care and trying to regulate, birth control and everything else. So I think people are becoming very fearful that they won't be able to dictate their own fertility in the future, even in our state.
And thinking about the implications, the ramifications on people who want to see, their pregnancy for full term, and if there are complications, what that would mean for them in another state. Depending on the law.
Right. And it's, and there are many people who have very wanted pregnancies who, end up having to terminate for their own health or for the well-being of their family. It's just not right for them to have either, to carry I'm sure Dr. Munoz sees a lot of, carry a baby to term and then only to know that the baby's going to die within a few hours or days. There's a lot of implications to these laws. Like if you're not going to be in Connecticut for a long time, what's going to happen if you have an anatomy scan in a state like that? There's a lot of anxiety around how you can get care and when the ball is going to drop. People are wondering, is Connecticut truly protected? What's coming down the line for women? It is on a lot of people's minds here.
Dr. Beverly Gray is an OB-GYN based in North Carolina. She's also with us here on Where We Live. Dr. Gray, welcome to our show.
Thank you so much for having me this morning.
You're in North Carolina, as I mentioned. So what does that mean in terms of the laws in your state?
So right now, there have been no immediate changes in the law with the Dobbs ruling. We have a law that's currently enjoined, that's a 20-week ban. That may change in the coming months, but currently we're able to provide comprehensive abortion care for our patients seeking it.
You mentioned that 20-week ban. I understand that you and some others were joined in action against the state regarding that ban. Can you tell us more?
Yeah, that's correct. So our previous law had a very narrow exception for cases between 20 weeks and viability. And so these are exactly the cases that Dr. Munoz was talking about, where someone comes in with a severe medical complication or illness and they're unable to receive care, or you have to have multiple experts, you're involving lawyers, and you're hindered in being able to do the right thing to save the person's life. And so, we had many examples of cases where, how sick does someone have to be before you care for them? Do they need to be in multiple organ failure, or is kidney failure enough? Or if they're, so there are these very gray areas where, people who are trying to, one, obey the law, but also do the right thing, can be, confused. And so by suing the state of North Carolina, our goal was to have clarity around that, Roe allowed for care through viability, and we felt that was the right thing to do for people in our state.
Now, looking into the future and the politics in North Carolina, how concerned are you about these laws becoming more restrictive?
Incredibly concerned. So right now we have a governor who stands up for reproductive health rights, which is awesome. He vetoes everything, all the restrictions that come across his desk. And right now there is no supermajority in the state House and Senate that would override these bills, but it's a very, very narrow margin. And so the elections in November are extremely important in our state for maintaining access to safe legal care. If they have a supermajority in the House or Senate, those bills could be vetoed and restrictive legislation could be pushed through as early as the spring. And so I would say that folks in our state are very, very concerned about that.
What are you hearing from your patients, Dr. Gray?
So, I also see patients who are more concerned about having more effective contraceptive methods. So we're definitely seeing that. We're booked out, as further than we've ever been in our family planning clinic for contraception. The other thing that's been really lovely to see is that patients are so appreciative when they're seeking abortion care with us. Just that we're there providing the care. They recognize that this right is tenuous right now in our country, and they're just so grateful.
Dr. Munoz, I'm wondering if you could respond to what your colleagues in other states have shared with us.
I definitely, I feel their sentiments, and it's true that we go through just this interesting experience of the barriers that we're trying to provide patient care. And Dr. Pascucci did mention that there are patients now that have fetal anomalies that we know are not compatible with life. And I've never had to manage a pregnancy through this, knowing that there's significant either like missing part of the fetal skull, and the what the patients are going through, and it's such a very difficult experience to go through patients with this experience because it's just different. And as Dr. Gray mentioned, even in my training for maternal fetal medicine and high risk OB, nobody ever told me what sick enough means. She mentioned, is kidney failure enough? That's just a ridiculous question that we're asking ourselves. Why do I have to ask, do you have 3 organs shutting down or 2 before we can provide you adequate care? That should just not be a question.
No. And when we think about even the maternal mortality rates increasing in our country, Texas alone, this has been a huge concern. And now what do we know about since these laws have passed, how that's impacting mothers, Dr. Munoz?
Yeah, an interesting study just came out last week by Dr. Nelson and his colleagues over in Dallas that showed since SB was implemented, their maternal morbidity rate has doubled for that age range of the 2018 and above.
Wow. Dr. Gray, I'm wondering if you could respond when you hear that really troubling study.
Yeah, we're living in a maternal health crisis in our country right now, and we know that folks seeking abortion care tend to have higher risks to their health and pregnancies anyway. And so, the question is, these folks will be forced to continue their pregnancies. We're going to need more high-risk doctors like Dr. Munoz to care for them. We're going to need more OB providers. We're already, in our state, we're a very rural state, North Carolina. We're already seeing, hospitals shutting down their obstetric services. So patients are having to travel further for care. There are just so many domino effects of cutting off access to abortion care that impacts families, that impacts people's work, that impacts, their chances of surviving their pregnancy. And so forcing pregnancy puts people's lives at risk.
Again, that's Dr. Beverly Gray, Associate Professor at Duke Obstetrics and Gynecology in North Carolina, as we talk with OB-GYNs today about their expectations and their fears in a post-Roe world. With us from Texas is Dr. Jessian Munoz, Maternal Fetal Medicine Specialist, and we heard from Dr. Kate Pascucci, who's with us from Connecticut OB-GYN. After a short break, we're going to talk with an infertility specialist, Dr. Amanda Kallen. Now, what questions do you have about the future of reproductive care? You can join us. 888-720-9677, or find us on Facebook. Search Where We Live. This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. Today we're talking about the future of reproductive health care in the U.S. with 4 OB-GYNs from our state, Texas, and North Carolina after the reversal of Roe v. Wade by the U.S. Supreme Court. Now this week, Connecticut's U.S. Senators Richard Blumenthal and Chris Murphy announced they're co-sponsoring the Freedom to Travel for Healthcare Act, which will protect the rights of Americans to cross state lines to receive abortion care. Now, the Roe reversal has wide implications also on patients trying to get pregnant through IVF. To explain, joining us now is Dr. Amanda Kallen, who's Associate Professor of Obstetrics and Gynecology at the Yale School of Medicine. Dr. Kallen, welcome back to the show.
Hi, thanks so much for having me.
I mentioned you specialize in infertility. So post-Roe, how are the conversations with your patients changing?
I think so. What we're seeing from our infertility patients is people are very scared about how access to fertility treatment is going to change and how decisions about what to do with embryos are going to change. I think some of the concerns are, for people who already have embryos frozen from IVF that maybe are excess or are abnormal or not, would not make a healthy pregnancy in the future. People are worried about what they're going to do with those embryos because the way that some of these laws are written, as personhood laws, there's a very real possibility that people won't necessarily be able to discard those embryos. Right now in Connecticut, people have the option to discard extra embryos or to make decisions with them based on what their family goals are. So patients are moving embryos around to different states. People are going to, I think, start making decisions about how many eggs they can get out of a cycle because they don't want to have extra embryos. That's going to increase cost. And so people are very, very worried about, how this changes their fertility options.
Now, in Connecticut, would you say patients, have better ease of mind versus thinking about these states that are, banning abortion and, requiring that, procedures must not be done unless there's no fetal heartbeat. I wonder if you can talk more about that, Dr. Kallen.
Yeah, I think people feel a little more at ease right now, but I think I don't think we can feel at ease. I think, a few years ago, we would have said Roe is not going to fall, and Roe has fallen. And so I think it's a mistake to think that Connecticut is safe. I think we are lucky right now because we have, legislators who are supportive of the full spectrum of reproductive rights, but that could change. And we've seen how that's changed in terms of Roe. So I think people are right to be nervous and scared.
We've done shows before on IVF and how it's complicated and, it can be quite a roller coaster for families. When we think even about some of the complications that may arise, even once a patient becomes pregnant in this way and how you're able to treat them, that must concern you, Dr. Kallen.
Yeah, it's terrifying. I have patients who have, and again, I think as Dr. Gray and Dr. Pascucci commented on, these are very wanted pregnancies. And, I've had patients who have had devastating, fetal anomalies, problems with the pregnancy, where that pregnancy, that baby is not going to survive. And, patients and families are making very, very difficult decisions about ending those pregnancies so they can try again for a healthy baby. And, I'm thinking of patients who would just be absolutely devastated to have to carry a pregnancy to term that would not survive. It's a devastating decision no matter what they do. And then, I think about my patients with ectopic pregnancies. So, when someone has IVF, they have a slightly higher risk of an ectopic pregnancy for some different reasons. An ectopic pregnancy is implanted outside the uterus. And, fortunately, this isn't something we're dealing with in Connecticut right now, but these are real conversations happening about, can I treat an ectopic pregnancy? if there's a heartbeat in the tube, we know that that pregnancy is going to not survive and kill the mother if it is allowed to continue. But how do we treat those pregnancies? So, right now, the way that the bills are worded, people are talking about having to ask their legal department if they can treat an ectopic pregnancy. These are situations that are life or death. You might have minutes to make a decision if someone's bleeding from an ectopic. And so, they're just absolutely terrifying situations. And it makes me sick to think about putting someone who is already in a difficult situation, already experiencing infertility, or just an unwanted pregnancy, and adding these layers of complexity to these decisions.
You can join our conversation, 888-720-9677, or find us on Facebook, search Where We Live. We have other OB-GYNs with us this hour, including Dr. Jessian Munoz, who's a maternal fetal medicine specialist practicing in Texas. Dr. Munoz, we heard from Dr. Kallen about, the questions for those who are undergoing IVF treatment. And I'm wondering if you can talk about that from the Texas perspective, these questions that are raised about how to handle when there are complications. What will happen with frozen embryos?
Yeah, it's such a difficult situation. And, I'm extremely grateful to have colleagues like Dr. Kallen, who do help a lot of these patients through their infertility. And many of these patients end up becoming patients in maternal fetal medicine. So we work very closely. And there are a lot of questions, where does this begin? And she also mentioned, ectopic pregnancies, and, how do we manage an ectopic pregnancy that has a heartbeat? It's possibly in her fallopian tube, which is connected to her blood vessels of her body. And, currently, do we let it grow until the blood vessels burst? And in pregnancy, the uterus can get up to 0.5 liter of blood per minute. So the bleeding is not slow. It's very brisk bleeding and very life-threatening bleeding. And these are situations, again, that when we did our training, this was never a question. These shouldn't be questions we're having today. We know what the answer is. The answer is, if we don't treat this, she's going to have life-threatening bleeding. But now the question is, how far do we let it go? What do we have to wait? How much bleeding is life-threatening? And these are questions that we should not be having to do. But unfortunately, this is where we are.
Dr. Kate Pascucci is also with us from Connecticut, OB-GYN. Dr. Pascucci, when we think even about the care in some states for these women who may be going through miscarriage and what that would mean for later-term miscarriage, I wonder if you can respond to that.
I think that it is an abomination that these questions are even having to be asked. Mm-hmm. It just really confirms that, I'm not really sure what the point of, wondering if you can treat an ectopic or wondering a miscarriage. The medical term for miscarriage is spontaneous abortion. I think that there's some confusion by the people that are making laws as to what a pregnancy is or what a life is. So we're basically putting the mother, but there's no end point to an ectopic pregnancy other than, treating the pregnancy so that the woman can continue to live. And if you don't do that, the woman dies. It's not, there should be, again, I echo the thoughts of Dr. Munoz and Dr. Kallen. It should not be, this is not a question. And these women, many times, ectopic pregnancies, miscarriage, it's devastating for them. And now we're questioning how to treat it and making it so much more difficult for them. And I think the problem is that people that are making laws really don't understand at all what we do and what we're faced with every day and what women are faced with their reproductive care. And, we're not talking where they're, even if people are saying, oh, it's not pro-life, it's pro-birth, but a ectopic pregnancy is not even pro anything. It's just silly to even consider having to face these decisions. I hope that in Connecticut, we will be able to continue to provide, that's not even good medical care. That's just being that's just, it's not even a thing. I mean, it's not even a question in my mind what we have to do for these patients. And I just can't even imagine being a doctor and going into this field, trying to take care of women and wondering, am I going to get like arrested for like doing my job? I mean, I feel very, I feel like it's insane.
Dr. Beverly Gray is with us from North Carolina. I wonder if you can respond to Dr. Pascucci and the others about, this idea, you're there to offer standard of care, and now to have to think about all these scenarios and how it's such a disservice to the people that you're trying to help.
I think it's incredibly important as medical providers that we have clarity, that we can speak with clarity around the differences between ectopic pregnancy and abortion. Seeking abortion care is ending a pregnancy that's implanted in the uterus, that's implanted in the normal place. Treating an ectopic pregnancy, the treatment is different. In my mind, it is completely different than abortion care. And I think as providers, we need to speak out with clarity about the differences, because if you have a patient with a ruptured ectopic pregnancy and you're on the phone with your lawyer, to me, that's malpractice. Like, you should be able to make decisions in the moment that save lives. And we know that in this country, the most common cause of death in the first trimester is either unrecognized or delayed treatment of an ectopic pregnancy. And like Dr. Munoz said, the uterus is an amazing organ and has, a blood supply during pregnancy that is impressive. And so if you have a ruptured pregnancy that's implanted not where it's supposed to be, you may have minutes of decision-making if that patient presents to you after their pregnancy is already ruptured. And as an OB-GYN that provides comprehensive care, I care for people that have ectopic pregnancies, who are seeking abortion care, who are seeking obstetric care. And I think the laws that are being put in place should not be clouding medical judgment, should not be forcing physicians to commit malpractice, which in my opinion, if you delay care of a known diagnosed ectopic pregnancy, that is malpractice.
Today, where we live, we're talking with OB-GYNs in our state as well as in Texas and North Carolina after the Supreme Court ruling overturning Roe v. Wade. You can join us with a question or comment, 888-720-9677, or find us on Facebook, search Where We Live. Dr. Munoz, who is practicing in Texas, I understand you're fairly early in your profession as an OB-GYN. What does this mean for you in your professional trajectory? Is this something that obviously you weren't expecting this? None of us were. Maybe some were, but in terms of your career and wanting to help your patients, I mean, how does this impact your future plans?
Yeah, this just has a profound impact on, just the care that I can provide, but also the training throughout the years. And it makes you really reflect about the training of our future physicians. I'm currently 3 years out, so I am considered junior in this field. But, the training that I received just 3 years ago is not going to be what our current OB residents receive. And, how we teach them to take care for patients in evidence-based care, that is completely disrupted now. And it's like this scramble, like, how do we prepare for the future? I really, I definitely fear for our patients today, but have a looming fear for the ones coming in the future, as training is going to be significantly impacted.
Well, what's your take? I understand there was clarifying guidance announced by the Biden administration earlier this week. I'm quoting CNN here now that the federal law preempts state abortion bans when emergency care is needed, and that the federal government can penalize institutions or providers that fail to provide abortions as needed to treat medical emergencies. Does that give you any ease of mind, Dr. Munoz?
No, it really doesn't. It just puts me again in another, crosshairs. Like, so where now the government says I can, but then the local government says I can't, and then the city will say something else, and you're now tiptoeing amongst all these different regulations and who's saying what. In the back of your mind, it's like, well, yeah, what if I do end up violating one of these laws, who's going to have my back? Who's going to be there to protect me and to protect my patients? Because, we see in situations like this that suddenly when things hit the fan, nobody's there. And so I think it just makes it overall more confusing.
Again, you can join us as we talk with OB-GYNs. Our phone number, 888-720-9677. That's 888-720-WNPR. We're talking to them about their expectations and their fears in a post-Roe world. We'll be back after a short break. This is Where We Live on Connecticut Public Radio. I'm Lucy Nalpathanchel. Coming up tomorrow, we're continuing to look at our country post-Roe, and we're going to focus on how some are worried about period tracking apps as a target of concern, but legal experts say the so-called digital dragnet is a much broader issue. Tomorrow we discuss how digital privacy is at risk and how can you be more diligent about your digital footprint. That conversation tomorrow. Now today we're talking with OB-GYNs about reproductive health care in a post-Roe world. With us on Zoom, Dr. Kate Pascucci with Connecticut Women OB-GYN, Dr. Beverly Gray, Associate Professor at Duke Obstetrics and Gynecology, Dr. Jessian Munoz, Maternal Fetal Medicine Specialist who practices in Texas, and Dr. Amanda Kallen, Associate Professor of Obstetrics and Gynecology at the Yale School of Medicine. Chris had a question from Wethersfield. Chris, you're on the show.
Yes, my question has to do with on all these big constitutional issues, a lot of, with the guns, we have gun lobbyists. And I want to know, do we have an AMA lobbying organization that can weigh in?
Chris, thank you for your question when you're thinking about, having the ear of lawmakers who are putting forth these policies. Dr. Kallen, I'm wondering if you can respond to Chris's question.
So I think there are several organizations that, are I think very passionate in terms of protecting access to reproductive rights, abortion care, the full spectrum of care. The American Medical Association is one of them. The AMA's principles of medical ethics don't prohibit a physician from performing an abortion, and the AMA has spoken out supporting access to abortion and promoting easier access to medication abortion. The American Society of Reproductive Medicine is very active in this space, focusing on access to care for fertility patients, but also promoting access to the full spectrum of reproductive rights. In Connecticut, we have the American College of Obstetrics and Gynecology. That's a national organization that is also active here in Connecticut. I'm the past chair of that organization here in Connecticut, and we are also very active. As we sort of talked about, our issues are a little bit different than perhaps the issues in Texas, but that doesn't mean that it's any less important to be active and to speak out. So yes, I think our local organizations are shouting about these issues, but the people who are making these laws, I think sometimes don't understand the very real and nuanced decision making that goes into, someone's fertility and reproductive decisions. And I think in some cases they do understand, and they are passing these laws anyway. I think in many cases, states and legislators know exactly what they're doing and exactly the positions that they're putting providers in, and it's an afterthought. It's about, it's about controlling these situations and taking these decisions away from patients and providers.
Before the break, I had asked Dr. Munoz about his career path, given that he's fairly new to practicing and with all of what we've just discussed. And I'm wondering, Dr. Beverly Gray, who's with us from North Carolina, how do you think pre-med or med school education or reproductive care might change given the Supreme Court's ruling?
So there are a lot of people speculating about what will change. I think the type of education that folks have is probably already very different depending on what state you're in and what type of institution you're learning in. I'm a residency director, so one of my concerns is how will these limitations impact our ability to train the next generation of providers? So if we go through a period of time where many or most states have very restrictive bans, there will be parts of the country where you won't have doctors who can provide that skill and that care in the second trimester. And Dr. Pascucci was talking about that earlier, that, it is a unique skill set. And so I think if you have restrictive bans, you're going to be training a group of residents that maybe don't have this skill set. I think it may also impact how people make decisions around their medical field of choice. People may have thoughts about, am I going to go into a field where I could be prosecuted for doing the right thing? That may be the case. I'm hoping that more than anything, that we will attract very passionate individuals who want to stand up for reproductive health rights in our country. But where those folks train will probably be dependent on the laws in different states. So we may miss out on some of the most competitive applicants in North Carolina if our laws change. So those are a couple of things that I'm thinking about kind of with my residency director hat on. And I'm definitely concerned about the future of our field.
And that is concerning. We think about, care deserts, so to speak, if certain areas don't have the right specialists to provide that care, Dr. Gray.
Absolutely. And then, like Dr. Munoz was talking about earlier, Texas is a huge state and there are probably vast areas where you don't have a provider. In North Carolina, only 9 counties in our state have an abortion care provider. And so the vast majority of counties don't have someone that can care for them. And then if you have a state where you have restrictions and you don't have people trained to care for patients in emergencies, even if we have these, federal regulations that are protecting us, if we don't have the skill to provide that care, then it puts patients' lives at risk.
Dr. Pascucci, who's still with us from Connecticut, OB-GYN, and I had to ask Dr. Gray to talk about, the future of med school education. I'm wondering what your thoughts are there.
I agree. I don't know how the people in those states will be able to train people appropriately, which will become a big problem in the future for women seeking care in those states, like if the laws change again in the future, or if people don't always train in the state where they end up living. So, and if there's laws saying that they can't train doctors to that, like I work at a Catholic institution, I have privileges at another institution so that I can provide abortion care to my patients. And the residents at our facility have opportunities to work with me. They also have opportunities to go to another hospital in New York that has a large family planning program to get the training that they need if they're interested in that. But I do think that it's something that lacks at the institution where I'm affiliated mainly, so I can't even imagine if there's like an entire state that is not training residents, like a state like Texas that has very good programs for medicine. They have, renowned institutions, and then they can't train anyone in abortion care. That is a big problem.
Dr. Kallen, your thoughts?
Yeah, I think that I think we are going to see loss of skills and loss of the ability for providers to take care of patients in the way that is most appropriate. And I also think that this applies not only to abortion care, but to miscarriage care. The surgical techniques used for abortion care are in many ways the same as those used for miscarriage care. And so if people are not gaining those skills, then I think people will be less likely to provide good care for someone who has a miscarriage. People will be less able to access the medications used to treat miscarriage, which are essentially the same as the medications used to provide a medication abortion. Already, you see, I can prescribe medication to treat a miscarriage to a patient, and that patient might go to a pharmacy, and the pharmacist might say, I'm not comfortable prescribing this, and object and make it very difficult for the patient to fill that medication, even if it's not for abortion care. And so I don't want to take away from the very real crisis of providing good, appropriate abortion care. I just want to point out that I think it extends even beyond that to these other consequences as well.
We're almost out of time. Dr. Jessian Munoz has also been with us from Texas, the maternal fetal medicine specialist. Dr. Munoz, what are your final thoughts for us here in Connecticut?
My final thoughts really are to think about not only today, but the future. As we've said here multiple times, this does affect our current patients, but also those upcoming. And, the skills in the way that we care for patients with termination of pregnancy, miscarriage are the same. And this parallel many things. This will affect us in the office. It will affect us on labor and delivery. And, the biggest thing we can do now publicly is make our voices heard, because now's the time.
Again, that's Dr. Jessian Munoz. Thank you for your time today on the show. We appreciate it.
No problem. Glad to be here.
Also here with us from North Carolina, Dr. Beverly Gray, who's Associate Professor at Duke Obstetrics and Gynecology. Thank you, Dr. Gray.
Absolutely. And, I just want to say that, abortion is really common. 1 in 4 women will have had an abortion by the time they reach menopause, which means that many listeners on your show today have had an abortion. Many people know or love someone who's had an abortion. And I think until people are faced with an unplanned pregnancy or an unintended pregnancy or an emergency situation with their pregnancy, it's impossible to understand the circumstances that people are facing. And people are the experts of their lives, and they deserve the right to make the healthcare decisions that are right for them with the guidance of their healthcare provider. So thank you for covering this very important topic.
Thank you, Dr. Gray. And also with us, Dr. Kate Pascucci from Connecticut Women OB-GYN and Dr. Amanda Kallen, Associate Professor of Obstetrics and Gynecology at the Yale School of Medicine. We appreciate your time as well. We're out of time. I'm Lucy Nalpathanchel. Today's show produced by Tess Terrible and Anya Grandalski. Our technical director is Kat Pastor. We'll be back tomorrow.